Welcome to our NHG RA Foundational video. RA is a key area of training in anesthesia residency, yet many of us start our residency journey without much prior exposure in RA. This video aims to give a brief introduction to RA as a whole, as well as an explanation of the workflow in our Tan Tock Seng's mobile block service. The aim is to help incoming juniors enjoy the process of learning RA instead of worrying about meeting clinical service requirements. And this is not meant to be a comprehensive guide in learning regional anesthesia, but at the end of the video, we will provide some good resources that we would like to recommend as well. We hope you enjoy and find this video helpful. So this video will be structured similar to the general workflow in our mobile block service, starting from the basic checks we do for every patient, all the way to our documentation and testing of the block. The following are some basic checks that we'll perform on every patient prior to performing a peripheral nerve block. You may take a screenshot to familiarize yourself with them. We are all familiar with how to document a nerve block as part of a surgery. However, when doing a standalone nerve block, you first have to change your context into the pain medicine context, and then you follow the steps in these two slides in order to sign in and side mark. After our basic checks, we then assemble our drugs and equipment, and the most essential of which are our ultrasound machine, the injectate, as well as the block needle or the catheter set. Next, we prepare our injectate, considering number 1, the drug to be used, and number 2, the concentration and volume that we want to prepare. For the drug to be used, we typically use lidocaine, bupivacaine or ropivacaine in Tan Tock Seng. We select our drug based on the onset timing that we need for the block to work, as well as the duration that we want the block to work. For instance, if the surgery is going to happen immediately after our nerve block, we will then select lidocaine because of its fast onset. Whereas, if we were to perform the block in induction room, and there's a separate surgery ongoing within the operating theatre, we may use purely ropivacaine in our injectate. Selecting the concentration and volume of our injectate depends on whether we're performing an anesthetic block, meaning that the regional technique is the main modality facilitating surgery, or we are performing an analgesic block, meaning that the regional block is part of a multimodal analgesia plan for the patient, or for pain control of a patient in the ward. For regional anesthetic purpose, we need a high density block, and to achieve that we use a higher concentration, for example 0.4% ropivacaine. Whereas if we are doing an analgesic block, for example all fascial plane blocks are actually analgesic blocks, and in order for the fascial plane block to achieve good analgesia, we need high volumes to cover the entire fascial plane, and we use a lower concentration to ensure that we do not go past the toxic limits.
Sometimes you may need to add adrenaline to your injectate as a marker of intravascular injection. So how do you do the calculation? We typically use a neat vial of adrenaline which contains 1 ml, and in this 1 ml there's 1000 micrograms of adrenaline in it. So the kind of concentrations that we use for our injectates include 1 in 400,000 and 1 in 200,000. Using an insulin syringe, you can draw up the neat adrenaline, and just remember that one small marking on this insulin syringe will give you 10 micrograms of adrenaline. So we usually add about 5 units of adrenaline to a 20 ml of LA. This contains 50 micrograms of adrenaline, and adding it to a 20 ml syringe of LA will give you a final concentration of 1 in 400,000 or 2.5 micrograms per ml of adrenaline in LA. So for a more concentrated, if you wish to have a 1 in 200,000 dilution of adrenaline, just use 10 units of this, which will give you 100 micrograms. And then if you put it in a 20 ml syringe, then you'll get 5 micrograms per ml of adrenaline.
This slide summarizes how we add adrenaline as an adjunct to our injectate. This is what our RA injectate tray will look like once we're done with our preparation. Note that our RA injectate is always prepared in a separate tray from our GA drugs to prevent any accidental intravascular administration of LA. After preparing the injectate, we then position our patient and ultrasound in an ergonomic fashion. We also perform a pre-scan to identify our patient's anatomy and to set the ultrasound settings to be appropriate for our nerve block. For this part, we're going to show how to manage basic ultrasound settings when using it for regional anesthesia. There are perhaps 5 things that you need to familiarize yourself with whenever you get any new ultrasound and you're performing regional anesthesia. The first is you must select the right probe. So in general, there are three types of probes in most ultrasound: the linear probe, curvilinear probe, as well as a hockey stick or a microlinear probe. As you go smaller, the resolution is higher, but the depth penetration is lower. So most starting ultrasound, we would use a linear probe, and for deeper blocks, we use a curvy linear. So after ensuring that you have selected the right probe, the second thing we would do is the exam, make sure that you're on the right setting, and we usually choose the nerve setting. The third thing is, of course, making sure that our depth and gain is appropriate for whichever body part we are performing the regional anesthesia on, and we can usually adjust that further when performing it. And the fifth function we need to familiarize ourselves with is how to use a color flow Doppler, so that when we are trying to avoid vascular structures, we know we can identify them. So just a quick demonstration on around the breaker artery, for example. So how we hold the probe, we usually hold close to the foot of the probe so that we have a more fine-tuned control over the probe. The next thing is also just to watch out for the wire. So sometimes it drags on the probe as such, and this causes either fatigue or it just compromises the image. So after getting a good grip and managing the wire, then you want to optimize the image. So for example, if this image is too dark, I'll optimize the gain and shallow the depth. So sometimes it's still not very clear where the artery is, so then you can just put on a color flow Doppler. So you can see that there's a vascular structure that you need to avoid. And then you press 2D to go back to 2D. Yeah, so now the gain is optimized and then you can proceed.
Now we will show how to prepare our RA trolley for a single shot as well as a continuous nerve block.
So now we'll be demonstrating what are the equipment that we need to do to prepare the RA trolley for a single shot peripheral nerve block. So this is the typical setup that we need. So these are the 6 things that we usually take up for a single shot. Out of these 6, this sterile glove, the coax, as well as the gauze can actually be taken from the RA trolley in the respective OTs. Whereas for the block needle, the lubricant as well as the tegaderm, we usually have to make sure in the morning that we have stocked up the Lamborghini or the Ferrari beforehand with adequate supplies of all 3. And before we open up anything, I think it's important to have a proper check. So especially for the block needle, you usually have to check that number 1 is not expired and it's the desired length for your block. So these are some important things to check. Then moving straight in, so normally we put everything aside first, so as to not clutter your trolley, and then we open up the gauze and the gloves first. So when you open it, you try to make sure that your gauze ends up on the plastic portion. This is to make sure that when you pour the coax, the sterility is preserved because the coax doesn't soak through. Okay. Then once you're done with that, the next thing you open is usually the gloves. So make sure you get your correct glove size. And then as you open, try to keep your contact usually limited to the edge of the packaging. So after that, then we will open up the nerve block needle that we have already checked previously. And then we can also open up the tegaderm. Then our gel. And then finally we will put the coax. So just make sure you are using the one that's the 2% coax with the 70% alcohol. Sometimes if it's not in the block trolley, you can find it on the surgical scrub side. So just make sure that it's soaked.
Alright, so this is the preparation for a catheter insertion. Alright, so before starting the procedure, it's done under a sterile technique. You need to wear the surgical gown and gloves. Alright, proceeding to the equipment that we need. Alright, so these are the equipment. So there is a standard AU-RA set. Alright, the AU will get it for you. You do need to prepare your epidural drape. Okay. Your needle that you wish to use. Do take note that because it's a catheter insertion, it's a Contiplex, and usually we use the Ultra. Do check that the length is the correct one. It's either a 50 mm or 100 mm. You will also need ultrasound drape. Right? Ultrasound drape. Sometimes this changes over time, so check with the nurses which one you're getting. These are the equipment that we need. Alright, so you need the various syringes, the 10 ml syringe, 2 of them. Do make sure that it is the lower lock. It can be taken from the 4th or 5th drawer in your AU trolley. Normal saline. The various needles. Do take note that our current lignocaine needs to be drawn with a injection needle. So do cater for that. And then you'll need a needle for the giving of the LA. You'll need your various injectate, either Marcaine or Ropivacaine. Right, and the other preparation includes the coax that you need to put into the trolley. Right, then at the end of the block, to dress the catheter, you need your epiglue to stick it down. You need one tegaderm, and usually the dressing, you need the window dressing that the AUs will prepare for you.
After assembling the components for our RA trolley, we then observe strict asepsis standards before we lay out the individual components inside our trolley. For single shot, we observe minimum a hand rub and donning of sterile gloves, whereas for catheter insertion, we will need to have our surgical hand wash, sterile gloves, and sterile gown as per a central neuroaxial block.
I will show you you how to prepare your tray. So first, make sure you do your hand rub, and then put on your sterile gloves, the appropriate size. The steps that you need to do to maintain sterility will be to drape your ultrasound probe and also remove this plastic sticker on your needle, which can be pulled out, and I will usually just loosen this as well. So this is a tegaderm that we use to cover the ultrasound probe, and the edges of it will be regarded as non-sterile once you have draped it on the probe. So you give some tension on the tegaderm and then place it neatly over the tegaderm edge, smoothing out the sides so that there's minimal air and gel is spread smoothly over the edge. And then, without touching the sides of the probe, remove the paper lining and pull down the dog ears. Then this will be your ultrasound probe. And try not to move your hand position after holding onto the probe, maintaining the sterile edge at the top. So with the other hand, you can connect the block needle to your syringe of local anesthetic and then prime it. You can get your assistant to help you as well. So make sure there's no air in your syringe and then just prime. Okay, so this white wire is a nerve stimulator wire. If you're not going to be using it for your block, you can remove it like so to prevent it from contaminating your block field. And then you can use the extra piece of the tegaderm backing to scoop up your gel so that you can smear on your ultrasound probe later.
Okay, so this is a simplified tray from the catheter insertion set. Right, we are missing a few things like the galley pot and some of the sticker for the application of the catheter at the end. For the galley pot itself, do take note that we usually put it separate from the tray so that the cleansing can be separate from all the equipment that is entering and touching the nerve, as the cleansing is usually neurotoxic. Right, so we'll demonstrate how to prepare the catheter. So you need normal saline. Okay, do take note that there are labels that come with the set, so use them to label your various fluids. Okay, so you have a 10 ml syringe, you draw up the normal saline. Okay, so this is what's within the set. You have the catheter needle with the clear tubing as well as the nerve stimulator wire. So sometimes if it's not needed, you can actually remove it from the needle. Right, so we start off by priming the clear tubing. Right, to avoid a mess, you usually prime it back into the same area. Okay. So make sure you pinch the tube and then cap it back. For the remaining normal saline, you can always draw more. You can use it to prime the catheter. Alright, so this is the catheter. Do take note that it's this to facilitate insertion of the catheter into the needle. Okay, there are two ends. One end with the black tip and the other markings is the one that goes into the patient, and the other end with just the black marking is the one that you attach to the crocodile clip. So this is the crocodile clip. To open it, you bend it at the tip over here. Then you'll click open. Then you take the end that is supposed to be inserted into the crocodile clip and put it all the way in, and then clip back the thing. Right? Then you can unscrew this part and prime the catheter. Okay. So same, when you prime, to avoid making a mess, try to prime it back into the tray. Right? So watch out for the fluid that is supposed to come out from the end, and do take note that there are multiple holes, not just at the tip, and make sure that all the holes are working and that there are fluid coming out from each hole. Sometimes if it's not, you can ask for a new set, it may not be working. Right, you also need to prime the filter. Alright, so just attach and prime, you can see it goes up. Alright, so it's primed. Alright, so we'll show how to pre-mount the catheter into the needle. Okay, so before that, we need to know how to count the markings on the catheter. So all the way to the back tip. Alright, at the first marking will be number 5, 6, 7, 8, 9, 10, which is the first double marking. 11, 12, 13, 14, 15 will be the first short and long marking. Alright, just take note that at this point, if you are inserting this into the needle, that if this long black line has entered the heart of the needle, usually it will mean that the catheter would have protruded from the tip by a couple of cm. So try not to insert all the way in, so to avoid shearing off the tip when you withdraw. Right, continue on. 16, 17, 18, 19, 20 is the first quadruple black line. For this catheter, it's a bit longer. You have additional markings up to 21, 22, 23, 24, and 25. Okay, so this is how you count the markings on the catheter. So usually the catheter comes with a green primer, this thing here, right, that you use to help facilitate the insertion of the catheter into the needle. Right, so how it works is that the needle usually has this part that is mounted. Alright, there is this little jelly-ish looking thing here. So the green tip actually clicks into place, right? After which the catheter can be easily inserted into the needle. Alright. So as mentioned, the black tip is approaching the hub. So if you look at the tip of the needle, the tip of the catheter is starting to protrude out. So we try not to push it all the way out and then pull it back in, as you might shear off the tip of the catheter. So we just usually leave it sheathed just right at the tip. Okay. After that is done, remember to click off the green primer so that the injectate does not leak out from that area. Right, you can either leave it in or you can just remove it at that point. So you can see that this black line is about 1 to 2 cm away from the hub. Okay, and then your needle is primed for insertion.
Finally, after all our preparation, we are now ready to position ourselves properly in order to start scanning and identify the anatomy at the block site. Good ergonomics is key in achieving a successful nerve block. This photo is a negative demonstration showing how we should not be positioning ourselves. This second photo is a positive demonstration of good ergonomics. Notice that in terms of operator, you should always stand with your back straight and shoulders relaxed. And in order to achieve that, you need to ensure that your table height is appropriately raised. Also, there is an appropriate space available for the operator's needling hand to maneuver. And the RA trolley is placed very close to the operator so that any changes in needles, in injectate can be quickly done. The ultrasound screen, very importantly, should always be along the same line of sight together with the block site and the operator so that there is not much turning and repositioning in order for the operator to see the ultrasound image and block site during the block performance. Finally, the patient's comfort is also important so that they do not move unnecessarily during the performance of the block. These are the different parts of the probe that the anaesthetist supervising your nerve block may refer to when trying to guide you through your nerve block.
Okay, so next we'll go through how to handle the ultrasound probe. So as mentioned before, get a comfortable grip that's stable and then rest your hand on the patient while you are scanning. So just focusing on the movement of the probe. So there are a few terminology to be familiar with. The first one is called sliding. You translate the probe with equal pressure along the patient's skin surface. Then you can also tilt the probe, which involves this movement, rotation in this plane. And then you may be able to rock the probe from side to side to improve your visualization of the needle. The aim is to ensure that the entire shaft of the needle is visualized with the bevel facing up. So always endeavor to make sure that the shaft of the needle is as aligned with the ultrasound probe as possible. Sometimes in the middle of procuring your image, you may lose sight of where your needle is, and it's always good to look down and try to move your probe to align with where your needle is. As you insert, also take care to ensure that the needle goes in at the midpoint of the ultrasound probe where the main beam is, so that will ensure that your needle visualization is optimized. So throughout your whole scanning process, this will give you the ideal visualization of the needle. A final note would be to exert just the right amount of pressure when you are scanning your image. Having firm pressure helps you to get good contact and ensure that all the important structures are visualized, but excessive pressure may result in important vascular structures being obliterated, and you wouldn't want to do that as you may inadvertently puncture them.
Finally, once we have acquired our good ultrasound images, we are now ready to insert our nerve block needle under a continuous in-plane visualization of our needle, especially the needle tip. These are the different parts of the nerve block needle, as well as some of its key differences compared to a normal needle. You'll soon hear your supervising anaesthetist continuously reminding you to keep your bevel facing up as you perform your nerve block. This zoom-in image shows you where exactly is the bevel of the needle tip.
So there's some instances where we'll need to use a nerve stimulator for our blocks. So this is the nerve stimulator we have in our OT. Okay, so it's the Bborn brand. So how you use it would be, okay, so this is the power. You turn this on. So there are different options that you can choose from. So usually we would start with these settings. This will be a milliampere, so we usually start at 5, so that is the maximum that we will set it at. The next button we'll press and choose would be milliseconds. So milliseconds would be the duration of the stimuli applied to the nerve, and usually that will be at 0.1 milliseconds. Next, we'll choose the frequency of how quickly the stimulus is given to the nerve, and that will be hertz, and we would usually choose 2 hertz. Next, what we would do, we would apply an electrode to the patient. This can be applied anywhere, and this will be the grounding electrode, and this electrode will be placed on the ECG lead. like this, okay, on any part of the patient. Next, with the peripheral nerve needle that you choose, you ask your AU to basically apply and connect the stimulating wire to the peripheral nerve stimulator. So with these settings, you can actually start performing your block. So with this knob over here, this is actually used to adjust the amount of current applied to the patient. So usually for a superficial type of block, the maximum current I will actually apply would be up to 1 milliampere. So you can adjust this. So basically by turning your knob clockwise, okay, you can actually increase, okay, the current given. For deeper type of blocks, you can actually start with 1.5 milliamperes. So that would be increased to 1.5. So you can actually apply and titrate the amount of current given to the patient by moving your knob.
Once we are done, we have to document our nerve block, and a common mistake is to forget to chart the drugs that we have used into the intraoperative drug chart. Finally, we have to always remember to test our block before we leave, and we can do so by reminding our surgeons to test the skin with a sharp-toothed forceps before they begin their first incision. Before we conclude this video, here are some general tips that we hope to share. Firstly, to maximize your learning each time you're attached to the mobile block service, it is a good habit to familiarize yourself with the OT list the next day to have a gauge of the blocks that are likely to be performed and to revise them beforehand. On a more service-oriented front, the first 2-3 blocks of the day usually tend to happen at 8:30 AM. Hence, it is important to also liaise with the different juniors and anaesthetists of this list to prioritize which case to do first. On your day as part of the RAMBO mobile block service, you can expect to receive multiple calls and texts requesting for blocks to be performed. On busy days, it's important to get information in order to prioritize the next few cases to be done. You want to know what block, which OT, what time. You want to know whether the patient is ready, and by that it means whether the basic checks have been done by the OT team. Some examples including making sure a working IV is present, consent has been taken. You want to know the indication because anesthesia or analgesia, for example, affects your injectate preparation. You want to know your basic patient profile to understand whether there are any contraindications. And in return, based on the information, you will prioritize when to perform the block, and you give the OT team a timing estimate. If you will be delayed, you can even ask the OT team to help you with the preparation of certain things to expedite the process. And in a worst case scenario, you may even ask them to look for another RA anaesthetist to assist with the block. Here are some key concepts you should understand before starting your RA journey. We have already covered the difference between anesthetic and analgesic blocks and how fascial plane blocks are always analgesic. Next, you must know the difference between superficial and deep blocks. Superficial blocks refers to blocks such as an interscalene block or a popliteal block, for example, which is easily compressible in the event of an inadvertent vascular injury. Whereas a deep block may refer to a block such as a paravertebral block, where you are unable to compress effectively the site of bleeding when an intravascular injury occurs. So the implication is that superficial blocks can be performed even when patients are on blood thinners or with disordered coagulation profiles, whereas deeper blocks should not be performed in patients with any bleeding concerns. Next, understanding the specific complication of each block usually depends on having a thorough understanding of the anatomy around the block. Choosing the right block for each patient requires us to know the probable site of pain, depending on the extent of surgery, our assessment of the patient, the use of tourniquets, and combining that knowledge with our understanding of the sensory distribution of each block. Finally, there are a few confusing terminology that we would like to clear up before you start your journey on RA. For brachial plexus blocks, they are usually referred to at the levels that the block is performed. For example, interscalene block is performed at the level of the root, whereas the axillary block is performed at the level of the branches. But these are all brachial plexus blocks, and they are not individual nerve blocks. For example, axillary brachial plexus block is very different from an axillary nerve block. Next, for the sciatic and femoral nerves, they can also be blocked at different levels. When we say a popliteal block, we usually are referring to a popliteal sciatic nerve block. There is no such thing as a popliteal nerve. And then for femoral blocks, they can be performed at the level of the crease, the femoral triangle, or the adductor canal. And these are all different levels to block the femoral nerve along its path. And more distally, the femoral nerve is also known as the saphenous nerve. When starting, it is easy to feel overwhelmed by the sheer number of blocks that can be learned. We recommend that you focus your energy mastering these 7 basic Plan A blocks first. These are internationally recognized blocks that every modern trained anaesthetist should be proficient in. In addition, we have bolded some of the blocks on this list which we find to be more clinically relevant in our local context. We have added on the infra-clavicular brachial plexus block to this list as we find that this is an easy block to perform when a continuous nerve catheter is required for the upper limb. As mentioned at the start, this video was created with the aim of making learning regional anesthesia an enjoyable process, very much like singing your favorite song at the kaRAoke.
Hence, this video is also part of an education project that we are affectionately calling kaRAoke. Conveniently, it has the letters RA in it. We have also created flashcards for the 7 basic Plan A blocks as well as Infra-clavicular Block, and these flashcards will be hung on RA ultrasounds. The intention is for these flashcards to serve as a tool to encourage on-the-job learning during our mobile block service sessions. There's just-in-time information for residents right before performing the block, and discussion questions to cement knowledge right after performing the block, and we hope you will find them useful. There is also a Google Drive link that we'll include in the description box of this video that you can visit for more additional resources. We have come to the end of our video. Here are some useful links that we'll also link down in our description box that we think you can visit to kickstart your journey in learning regional anesthesia. We hope that this video has been helpful in kickstarting your RA journey.